Hello and welcome back to the Biochemistry for Health Sciences channel. In today's video, we shall discuss glucose in the body as well as the blood glucose test. In the previous videos, we covered the foundations of biochemistry. Now in future videos, starting from this video about blood glucose, we are going to use this knowledge, this foundational biochemical knowledge, and try to connect this knowledge to other basic medical science concepts, especially those in physiology, pathology, as well as pharmacology. One good way of making these connections between biochemistry and other medical science classes is a discussion on the chemistry tests that are commonly used by clinicians for the diagnosis as well as monitoring of various diseases. In today's video, we shall look at glucose. As we discussed in a previous video on glucose, most of the glucose in water, or in this case, we are more interested in glucose in our body, especially our blood and the fluids in our body, most of the glucose exists in this cyclic form. So more than 99% of the glucose is in this cyclic form. And notice that in this cyclic form, there is no aldehydes or ketones. So therefore, this is much less reactive and it's a much safer form of glucose as far as reactions with other chemicals is concerned. However, there is a small amount of glucose that is found in the aldehyde form. Now, the aldehyde form reacts with amines, and as we now know that proteins do most of the things for cells, so this aldehyde form of glucose can react with any protein where the amine is exposed, and it can then form all kinds of chemical products that eventually will impair the protein function. And since proteins do most of the things for cells, that is going to impair the cellular functions. So this form here is actually the basis for this test called A1C and fructosamine that we talked about in a previous video on carbohydrates, and we'll briefly mention about these tests later on in this video. A few words about the units of glucose. Milligram per deciliter versus millimoles per liter. Now in USA, milligrams per deciliter is how glucose concentration is reported. In several other countries, glucose concentration is reported in millimoles per liter. And you can see from this, you can pause the video and study these calculations if you're not familiar with this. If you get a value in milligrams per deciliter, all you have to do is divide it by 18, and that will give you a value in millimoles per liter. So for example, if you had 100 milligrams per deciliter, if you divide it by 18, you would get 5.6 millimolar. After the clinician gets the blood glucose concentration of the patient, if the result is not within the standard range, then the most important question in the clinician's mind is, why is the glucose either higher than the standard range or lower than the standard range? So high glucose is hyperglycemia, or a low glucose is hypoglycemia. So what's the reason for either the hyperglycemia or hypoglycemia? So that's an important clinical question and an important use for these blood tests. Now, to answer this question, it's important that we understand the life story of glucose in the body. So this is something we sort of mentioned early on, how important it is to understand the life stories of chemicals in the body, and that was mentioned in video 1.5. As we talked about in video 1.5, we used this concept called ADME. This is a concept actually used by pharmacologists. Absorption, where did the drug, because pharmacologists are only interested in drugs and all drugs are foreign chemicals. So where did the foreign chemical in the blood come from? Did it come from a diet? Was it injected? Did you inhale it? And so on. Then the next question is distribution, the D. How does the drug travel in the bloodstream? Does it freely dissolve in the water of the blood, or does it require a protein to bind to the drug so that it can travel in your bloodstream? That's called distribution. And then metabolism, how is the drug metabolized? And finally excretion, how is the drug excreted? So this ADME is a very important concept for pharmacologists. Now, in case of biochemistry, we'll modify this ADME. Instead of A, we'll use O, and O is origin. That means where did the blood glucose come from? Now, glucose could be a foreign molecule like a drug, but glucose is also produced in the human body. So that's why instead of A, absorption, because all drugs are foreign and they have to be absorbed, we will use O, origin. The rest is the same: distribution, how does glucose travel in the bloodstream, metabolism, how is glucose metabolized, and finally, how is glucose excreted. So origin, where did the blood glucose come from? It could come from your diet. So in that case, like a drug, it is a foreign chemical. Or it could come from within your body. So the origin could be right within your body. And we've talked about this in previous videos on metabolism. Glucose is made by gluconeogenesis, especially in the liver. And some gluconeogenesis does also happen in the kidneys and intestine. And glucose also can come from the breakdown of glycogen. So glycogenolysis. So glucose can be made from the body, and glucose can be a foreign chemical. So that's the origin of glucose. A few words about glucose as a foreign molecule. Glucose in your diet has to be absorbed into your bloodstream. So the dietary glucose has to be absorbed into the bloodstream as a foreign molecule in your diet, and that is done, of course, by digestion. So the enzymes like amylase that break down starch, glycogen, and so on to maltose, and then there are disaccharidases that break down various disaccharides into glucose and other sugars, and the end result is we have our glucose, our monosaccharide, after digestion. So once we have the glucose, now we need to take the glucose into the blood vessel. And this occurs in the intestinal cells, the intestinal epithelial cells, especially the enterocytes. So these cells have two very important proteins. One is SGLT, sodium-dependent glucose transporter. And this brings in glucose as well as sodium into the cell. The sodium-potassium pump will always keep the sodium concentration very low in the cell. So because the sodium is much higher outside, this force of driving sodium from high to low concentration also helps the glucose coming from the outside into the enterocyte. Now, once the glucose is inside the enterocyte, then it will be transported out into the interstitial fluid and then eventually into the blood. And this transport out of the enterocyte is done by another protein, another transport protein called GLUT2. So with the help of various digestive enzymes, glucose is generated and in the intestinal cavity, and then with the help of these transport proteins, SGLT, the sodium potassium pump, and GLUT2, this glucose is transported across the enterocyte, the intestinal cell, and it enters the bloodstream. So now glucose is in the bloodstream. Now glucose has a lot of hydroxyl groups, so the carbons are attached to several hydroxyl groups. And remember from an earlier video on solubility of chemicals in water, chemicals that are rich in hydroxyl groups are very water soluble. So glucose simply dissolves in the water part of the blood. It does not require any special transport protein to transport glucose. So distribution of glucose is very simple. It simply travels in your blood and it travels along in your bloodstream, simply dissolved as glucose. And then under metabolism, we talked about how is glucose metabolized. So for example, after a meal, postprandial, after a meal, there is a lot of insulin secretion from the beta cells of the pancreas. So that's one key thing that happens. There is a lot of glucose absorption from the GI tract into the bloodstream. There's also a lot of glucose being taken up by cells, especially the adipocytes and the muscle cells. So there's a lot of glucose uptake. And a lot of this glucose is also converted into glycogen by this process called glycogen synthesis or glycogenesis. So these are some of the key events that happen that we talked about on the postprandial in videos on metabolism. What happens during the fasting state? During fasting, instead of insulin, there is a lot of glucagons. Glucagon secretion is high. And there is these two key things that happen. Gluconeogenesis, synthesis of new glucose, which is mostly done by the liver. Some of it also is done by the kidneys as well as the GI tract. And then there is glycogenolysis, breakdown of glycogen to form glucose, and then this glucose enters the bloodstream. So these are the key events that happen in glucose metabolism. Now what about glucose excretion? How is glucose excreted? Glucose is excreted if our blood glucose concentration exceeds a threshold of about 180 milligrams per deciliter. So if your blood glucose goes more than 180 milligrams per deciliter, then we could see glucose in the urine. That excess glucose is excreted into the urine. Now, glucose is a small molecule, molecular weight only about 180. So this glucose in your bloodstream, all of it, as it travels through the kidneys, it will be filtered by glomerular filtration membrane, because the cutoff of this membrane is about 40,000. That means any chemical that has a molecular weight less than 40,000 has a good chance of escaping this membrane and entering the tubule. Then glucose is very small. 180 is very small compared to 40,000. So it's very readily filtered, and it's water soluble, so it has no problem getting filtered into the renal tubules. Now once the glucose is in the renal tubules, as long as the concentration in the blood is less than 180, then all of this glucose will be reabsorbed back into the bloodstream. And this reabsorption is very similar to the absorption that we discussed in the GI tract. The protein SGLT is involved here, then the protein GLUT2 is involved here, and glucose enters the cell, the proximal convoluted tubule epithelial cell. This is the epithelial cell that's lining the proximal convoluted tubule. The glucose enters and is reabsorbed. I guess that's why we use the term reabsorption, because we absorb glucose first in the GI tract, and now we are reabsorbing glucose back into the bloodstream in the kidneys. Okay, so with that life story of glucose, the origin, the distribution, the metabolism, and the excretion, now we should be in a better position to understand why is the patient's blood glucose high or why is it low. So let's talk about hyperglycemia. What are the main causes of hyperglycemia, especially now that we understand ODME? We are not going to talk about genetic diseases that can cause hyperglycemia. We will leave this part for future videos on genetic diseases, because genetic diseases, discussion on genetic diseases is yet another way of connecting biochemical concepts with other medical science concepts. So we'll leave this for future videos. So typically hyperglycemia is considered when your blood glucose is greater than 125 milligrams per deciliter. Now notice when we say blood glucose, we mean fasting blood glucose. Okay, fasting blood glucose. So most of these blood glucose tests done by the chemistry lab is on blood glucose specimens taken when the patient is fasting, which usually typically is first thing in the morning before breakfast. The blood is taken and the glucose is measured. Okay, so what are the common reasons for a high blood glucose? Now, as we discussed in previous videos on metabolism, there are several hormones that affect glucose metabolism. One of them is insulin. So if you go back to video 6.9, we discuss all the various effects of insulin on the liver, on adipocytes, on muscles. The end result of this is insulin decreases blood glucose. So the presence of insulin is going to cause a decrease in blood glucose. So one reason for hyperglycemia is diabetes. In type 1 diabetes, there is either a reduced or absent secretion of insulin. Since insulin reduces blood glucose, if you don't have insulin, your blood glucose is going to increase. It's going to lead to hyperglycemia. So type 1, where there's reduced or absent insulin, and then in type 2, there is insulin present, but the insulin doesn't work. There's insulin resistance. So in type 2, the cells are not responding to the insulin, and since the cells are not responding to insulin, the beta cells in the pancreas that are secreting insulin, they will start secreting more and more insulin until they basically wear out. Okay, so type 1 and type 2 diabetes is a very common cause for hyperglycemia, high blood glucose. And this is where the fasting blood glucose test is most commonly used for the diagnosis and monitoring of either type 1 diabetes or type 2 diabetes. Let's look at a few other causes of hyperglycemia. Pancreatitis, there is inflammation of the pancreas, and if this inflammation affects the function of the beta cells, then there is beta cell damage, and now there won't be enough insulin secreted, and because of reduced insulin, there is going to be hyperglycemia, high blood glucose. So that could be another reason for hyperglycemia, pancreatitis. Then there are drugs that can suppress insulin release by the pancreas. So examples of these drugs are drugs that treat hyperinsulinism, too much insulin in the blood. And examples of these drugs include diazoside, octreotide, as well as other drugs that patients may be taking for other diseases, such as the tricyclic antidepressants, as well as diuretics. These drugs can also suppress insulin release, and if there is less insulin release, that is going to lead to hyperglycemia. Now, besides insulin, another hormone that affects glucose metabolism that we discussed under metabolism is glucagon. So in video 6.13, we showed how glucagon, the effects of glucagon on the body, and how glucagon increases blood glucose. So while insulin decreases blood glucose, glucagon increases your blood glucose. So for review, you can go back to video 6.13 and review how glucagon affects the body, how it causes increased blood glucose due to various effects on the liver. So it makes sense that if glucagon increases blood glucose, and if we have too much glucagon secretion, for example, in the pancreatic tumor, what we call glucanoma, there's a tumor of the alpha cells. The alpha cells here have divided. Many alpha cells are being formed in this tumor, and they are functional. They are actually secreting glucagon, so your glucagon levels go very high. You have very high glucagon in your blood, and that's going to, because glucagon increases blood glucose, that's going to cause hyperglycemia. Another set of hormones that affect glucose metabolism are the catecholamines. And in video 6.14, we discussed how catecholamines increase blood glucose. Just like glucagon, they increase blood glucose. So it makes sense that if there's any condition that increases catecholamine secretion, and since catecholamines increase blood glucose, that is going to lead to hyperglycemia. So for example, in the adrenal medulla tumor called pheochromocytoma, there is these cells, excessive amounts of these cells in this tumor that secrete epinephrine. And epinephrine is an example of a catecholamine. So there's going to be increased epinephrine secretion, and that's going to lead to increased blood glucose, hyperglycemia. Now, acute stress, as you know, epinephrine is released in acute stress in the clinical setting. For example, stress of just being in a hospital, visiting a doctor, for example, or the stress after post-surgery can cause increased epinephrine, and that increased epinephrine can lead to hyperglycemia. Another hormone that affects glucose metabolism is cortisol. So in 6.14, we saw how cortisol, once again, like glucagon and catecholamines, increases your blood glucose. So cortisol increases blood glucose. So it makes sense that if there's any disease or condition that increases cortisol secretion, that is going to lead to hyperglycemia. So for example, in the disease Cushing syndrome, again, there is a tumor that's producing excess ACTH. So this is a pituitary tumor that's making a lot of ACTH. Now, ACTH will go to the adrenal cortex and stimulate cortisol secretion. So this is going to lead to high amounts of cortisol in your bloodstream. Similarly, there are tumors called ectopic tumors. Ectopic means out of place. So these tumors, for example, might be found in the lungs, and lungs is not a place where you see ACTH being secreted. Okay, ACTH comes from the pituitary gland, but these tumors in the lungs are also making ACTH, ectopic tumor. And this ACTH, once again, will go to the adrenal cortex and it will stimulate the secretion of cortisol. So besides tumors secreting ACTH, there are also tumors, adrenal tumors, in the adrenal cortex, and these cells secrete increasing amounts of cortisol, and that too can lead to hyperglycemia. So tumors present in the pituitary or other organs, as well as tumors present in the adrenal cortex, can all lead to increased cortisol and hyperglycemia. And then we have corticosteroid drugs that are used quite often for controlling inflammation. These drugs are basically cortisol, and if in high doses, these cortisol levels can increase and cause hyperglycemia. And cortisol is released during chronic stress. So under chronic stress, the high amounts of cortisol can lead to hyperglycemia. Yet another hormone that we discussed in video 6.14 that affects glucose metabolism is growth hormone. So we saw in video 6.14, growth hormone increases your blood glucose. Okay, so once again, growth hormone increases blood glucose. So again, if there is excess growth hormone, that is going to increase your blood glucose and cause hyperglycemia. Examples of increased growth hormone secretion we see in this disease acromegaly, where there is a pituitary tumor that is making a lot of growth hormone. So it's going to be high growth hormone in the bloodstream and hyperglycemia. And then, of course, there are ectopic tumors. So tumor, for example, in the lung is actually making growth hormone. Okay, should not be making growth hormone because growth hormone comes from the pituitary gland. But yet this tumor in the lung or the pancreas or somewhere else is making growth hormone. And this growth hormone enters the bloodstream and causes increased blood glucose hyperglycemia. Again, in video 6.14, we saw how thyroid hormones increase blood glucose. Okay, yet another hormone that increases blood glucose. So not surprisingly, if the thyroid gland is secreting too much thyroid hormones, what we call hyperthyroidism, T4, T3 are the two major thyroid hormones, that increased thyroid hormones is going to increase blood glucose hyperglycemia. Okay, so what about hypoglycemia, when the blood glucose goes below a level of about less than 70 milligrams per deciliter? So besides genetic diseases that we'll talk about in future videos, what are the common causes of low blood glucose? Now, since insulin decreases blood glucose, so excess insulin, which can come from in diabetic patients if they injected themselves with too much insulin, or diabetic patients who take this drug sulfonylurea, that can cause excess insulin in the blood, and that can lead to hypoglycemia. Now, sulfonylurea is a drug that closes the ATP-sensitive potassium channels. Refer back to video 6.8 where we discuss how insulin is secreted by the beta cells. Okay, so this closing of the potassium channels is going to stimulate insulin release even when the blood glucose is low. So insulin keeps on coming out. Doesn't matter whether blood glucose is high or low, the sulfonylurea will cause these beta cells to continuously release insulin. So this excess insulin and insulin decreases blood glucose is going to lead to hypoglycemia. Hypoglycemia. Now there is this hormone called glucagon-like peptide 1 or GLP-1. This is secreted by the intestinal L cells, and GLP-1 goes to the pancreas and stimulates insulin release and inhibits glucagon secretion. So the stimulation of insulin release once again is going to cause high insulin, which is going to lower your blood glucose and lead to hypoglycemia. Now there is a drug called GLP-1 mimic drug, which is example semaglutide or Ozempic, used for diabetic patients. This drug basically behaves like a GLP-1. That's why we call it a GLP-1 mimic drug. Okay, so this drug basically will go to the pancreas, stimulate insulin release, inhibit glucagon secretion, and that's going to lead to, if there's too much of that, that's going to decrease your blood glucose very low and produce hypoglycemia. Now, as we mentioned earlier, catecholamines increase blood glucose, but if you use medications that block these catecholamine actions, because catecholamines like epinephrine, for example, actually use beta receptors to exert their effects. So if we use drugs that block these beta receptors, the epinephrine is not going to work. So the catecholamines are not going to work, and since they increase blood glucose, without the catecholamines, there's a good chance of decreasing your blood glucose, leading to hypoglycemia. So medications such as beta blockers can cause hypoglycemia. Now, consumption of alcohol, especially during the starvation state, if you have not eaten anything, in this case, the liver is very busy in detoxifying the alcohol. So the liver is going to, there's going to be less glycogen breakdown and less glucose formation in the liver. Why? Because the liver is just overwhelmed with detoxifying alcohol. And without glycogen breakdown and gluconeogenesis, that's going to lead to a decreased blood glucose or hypoglycemia. Exercise can also lead to hypoglycemia. So during exercise, there is a non-insulin dependent GLUT4 transport to plasma membrane. So even without much insulin, the GLUT4 proteins appear on the plasma membrane of these muscle cells. And more GLUT4 means more and more glucose can enter the muscle cells. So much so that this consumption of glucose by the muscle cells exceed the release of glucose by the liver. So more and more glucose is entering muscles compared to release by liver, and that's going to cause decreased glucose or hypoglycemia. As mentioned earlier, cortisol increases blood glucose. So if for any reason there is insufficient cortisol, that can lead to hypoglycemia, low blood glucose. And an example is in Addison's disease, where the adrenal gland is destroyed by either autoimmune disease or infections, or even sometimes cancer. So in this case, there is decreased cortisol production, and that can lead to hypoglycemia, low blood glucose. Thyroid hormones, as we saw, increases blood glucose. So if there is less secretion of thyroid hormones, what we call as hypothyroidism, less T4, T3, that can also lead to hypoglycemia. Now, excess insulin due to this pancreatic tumor, what we call insulinoma or necidioblastosis, this tumor in the pancreas can secrete a lot of insulin, and as we saw earlier, insulin decreases your blood glucose, and that can lead to hypoglycemia. There are other causes of hypoglycemia, for example, when there is GI surgery or severe GI infections of the gastrointestinal tract. That's going to affect glucose absorption into the bloodstream, and that can lead to hypoglycemia. And then there is this what we call reactive hypoglycemia. In some cases, there is an insulin surge, a huge increase in insulin when too much carbohydrate is ingested, and that this large concentration of insulin can lead to hypoglycemia. Okay, so that's a few examples of some of the common reasons for hyper and hypoglycemia. A few words about blood glucose analysis. Glucose is measured sometimes in the plasma. So in this case, the blood is collected and then simply centrifuged. And when you centrifuge, all the blood cells go to the bottom. Then the top is plasma, and this plasma can be used for glucose analysis. Sometimes it's measured in serum. Okay, now in serum, you have to wait for the blood to clot. It takes about 10-15 minutes, and after the blood is clotted, then we centrifuge the blood, and the clotted blood will be at the bottom here, and on the top we'll have this liquid called serum that can be used for glucose analysis. Today, there are several home instruments and office instruments that are used to measure blood glucose. In this case, the glucose is measured in whole blood. The finger is basically pricked, and the blood sample goes into the instrument, and the glucose is analyzed. Now, glucose can also be measured in the urine. This is part of urinalysis. Normally, there should not be any glucose present, but if the glucose concentration in the blood is very high, greater than 180, then the glucose is excreted in the urine. And in that case, when the dipstick is dipped into the urine, the pad changes color, indicating there is glucose present. Glucose is also sometimes analyzed in cerebrospinal fluid, which is collected by lumbar puncture. You can see the reference range of glucose in the CSF is less than that in blood. The main use of CSF glucose is for bacterial meningitis. So if the CSF contains bacteria, these bacteria will use up the glucose for their energy needs, and the glucose concentration will drop down to as low as less than 30 milligrams per deciliter. So that's all for the glucose test. In the next video, we shall discuss glycosylated hemoglobin, which is another test that is important for diabetes diagnosis as well as monitoring. And this was briefly discussed in video 2.74. We will also discuss the fructosamine test in the next video, which was also briefly covered in video 2.74. So until the next video, thank you very much for watching and supporting this channel. Have a wonderful day, and we'll see you in the next video.